Hey guys, welcome back to part 2 of cervical discectomy and fusion. If you remember from the first half, we really spent a lot of time just going over anatomy and talking about what we call the clinical practice guidelines for cervical pain, neck pain. And we focused on 2 patterns that you might see that relate directly to requiring cervical surgeries of any kind. And so those are going to be mobility deficits and radiating pain, with radiating pain being the primary pattern that we see. And so we talked a little bit more in detail about these patterns. And I have the treatment here. And so if these patients are being seen with just really more of a mobility deficit, which following surgery, they're basically presenting with mobility deficit. So we're hoping they don't have radiating pain any longer. And so we're treating them and assessing them for their mobility issues and then treating them for those issues following the fusion, recognizing that obviously if there's a fusion, they're not going to be able to move at that level. We also kind of reviewed anatomy related to muscles, since these muscles are going to be important muscle groups, things like the deep neck flexors, to think about and make sure that they're working well following surgery. And we talked about the radiating pain pattern, which is going to be the primary focus of non-operative treatment for these patients. Again, we're hoping that these patients, if they need surgery, they're having surgery and then they don't require or they're not presenting with radiating pain following surgery. So radiating pain, we're thinking about specific nerve roots and then the nerves that travel down the arm. And those primary nerves are going to be median, ulnar, and radial nerve. And so we have 4 tests, if you remember, that we can use to assess for nerve root problems. And those tests are a Sperling's test, the upper limb tension testing, providing actually decreased symptoms with cervical distraction, and then looking for any issues with myotomal weakness, dermatomal changes, or reflexes. So we reviewed the nerves and how we test them, and we'll hopefully have time in lab to go over that if we need to. And then we talked about when is surgery appropriate. And if there are symptoms related to cervical myelopathy, this is going to be the primary thing. So this means that there's some sort of central cord problem. And so there are some tests that we can look at that show us that central cord problem. Probably your surgeon or a doctor is going to be performing those. But we're also looking for significant radiating pain symptoms. And that usually happens with different types of issues of narrowing around the nerve root or the spinal cord. And so this tends to be something that's common in men in their mid-age or so for whatever reasons. And they're going to come to us again, possibly presenting with headaches, neck pain, upper back pain, but also it's those radicular symptoms that we're really looking for. So if you're seeing them non-operatively, then you're thinking about that radiating pain pattern from our clinical practice guidelines. But there's also the possibility that surgery is going to be necessary. And usually when this happens, it's because we have a disc herniation that is affecting spinal cord or nerve root. Also, if there's osteophytes, so bony growth from the facet joint that's affecting nerve root. And then when we don't expect surgery to happen is if there's just neck pain. So we talked about how they could have neck pain, they could have headaches, they could have upper back pain. If there are no neurological symptoms, then they will not perform surgery, okay? So unfortunately in China, I'm seeing a little bit more surgery than is necessary. When I talk to the patient, most of them are reporting that before the surgery they had some radiating pain, but some of them aren't. And that to me makes me question whether or not that surgery was appropriate. Also, if they're just demonstrating cervical instability, so this can happen after a car accident or any other type of accident. And so this also can happen with people who have Down syndrome or some other types of pathologies like rheumatoid arthritis. These are not patients that they're going to fuse. What they're going to do instead is usually provide physical therapy for stability. And then symptomatic central disc herniation means that they have that referred pain, like we talked about with the low back. These are not patients, again, that they're going to provide surgery for. These are just patients that we're going to be doing therapy for, waiting for that disc to heal, just like with our patients who have lumbar central disc herniations. Kyphotic deformities of the spine, also not a reason to do surgery. So kyphotic deformities meaning you have those patients who come in and tell you, my neck is flat. I had somebody tell me that my neck is flat, that I don't have a good basically lordotic curve. And of course, we all know that that doesn't mean anything if there aren't any symptoms. And so again, if they're coming in and reporting that they have maybe a mobility deficit or reports of headaches, then that's something we treat. If they don't have any symptoms, we don't treat them. And then if they do have issues related to nerve root, then this might be a surgical candidate, or we may end up doing conservative treatment. So we already talked about the fact that these are sort of the things that we look for to assess whether or not there's radiculopathy. So we're doing upper limb tension testing, we're doing distraction, we're doing a Sperling's, we're looking at range of motion. So if there's a significant range of motion measured decrease, mobility, and then these other things, then we're considering that there's a nerve root involved. And so again, the surgeon is the person who makes that decision of if surgery is appropriate. And so if surgery is appropriate, this is our technique. We have two different options, the anterior decompression with fusion and a posterior decompression. And they may just do decompression from the posterior approach with or without fusion. But I would say the vast majority of the time, we're going to see the anterior approach, the anterior decompression with fusion. And I am seeing these more and more in China, but I am seeing posterior decompressions as well. So we do have videos, but let's talk about the anterior decompression first. What's nice about the anterior decompression is that it doesn't affect the muscles as much. So if you come anteriorly, then we're not affecting all those muscles that we talked about around the spine quite as much. But you do have to move the laryngeal nerve and the trachea and to be able to get to the vertebrae. So this does lead to difficulty swallowing and some pain, usually around the throat after the surgery. Basically what they do is they remove a lot of the disc and then they will insert a bone graft. So they're putting something like a spacer in between the vertebrae and then putting in the hardware. So again, this is the most common surgery that we see in the US, but I am seeing a lot more posterior surgeries here. And sometimes they'll just go in and decompress the nerve. So they'll just kind of open up the space, either with a laminectomy or some sort of discectomy. But these unfortunately need, they're more likely to have complications and require a second surgery. They oftentimes will do a full laminectomy in these cases, meaning they cut on either side of the facet joint and they remove the spinous process with the lamina. So they just don't have a spinous process anymore. So again, they then fuse or they just do the laminectomy. So they may not use hardware to fuse. They may just cut out the bone. And it sounds scary, but it actually works just fine. I think in the United States, they're performing these posterior surgeries and just performing the laminectomy. They're not actually fusing anything. They're just kind of opening up the space around the nerve root and the spinal cord. So let's take a look at the video for the surgery.
Anterior cervical discectomy procedures are usually performed to remove pressure on nerves from disc herniations. A disc herniates when the outer portion of the disc ruptures and some of the softer disc nucleus material squeezes out. The herniated disc pushes against the spinal cord or spinal nerves and tends to cause pain in the neck or arms. Removing the ruptured disc alleviates pressure on the nerves or spinal cord, which usually relieves the pain. A bone graft is usually inserted with instrumentation to keep the disc space at a normal height and fuse the vertebrae above and below the removed disc. An incision is made to one side on the front of the neck. Through this incision, exposure is provided to the front of the cervical spine. The herniated disc that is causing pressure on the spinal nerve is located between vertebrae. Surgical instruments are used to remove a portion of the herniated disc, which alleviates pressure on the nerve. After disc material is removed, a bone graft is cut to the correct size and placed in between the vertebrae to add stability. A metal plate is placed over the bone graft, and 2 holes are drilled in each vertebra. 4 screws are placed through the plate to secure the plate to the vertebra. The metal plate provides additional support while the bone graft grows in place, fusing the vertebrae. The incision is closed and dressed to complete the surgery. Some patients require a cervical collar for a short period of time after surgery. Most patients notice rapid improvement of their arm pain.
Okay, so that's our surgery. It's rare in China that I see just 2 levels fused. Usually the fusion is lots of levels because it's usually after some sort of trauma and the doctors aren't really sure what else to do. So it's a little bit different issue. But the anterior approach, that very simple, what you just saw in the video, we're hoping that that's the kind of thing that happens a little bit more frequently. Hopefully that's the kind of thing you're seeing. So unfortunately with complications related to fusion, anterior approach, you can see that because they have to go around the trachea and the vocal cords, that there can be issues with that. So they could lose their ability to speak or have issues with coughing or breathing. They also could end up with contusions to the spinal cord, so they could have gotten some sort of trauma to the spinal cord, so that actually leads to more symptoms. Infection is always an issue, but there's much more likelihood of a non-union. It's not very likely if they just did a single level discectomy or fusion, but if they're doing 2 or 3 levels, then you're much more likely to have some sort of non-union, meaning that it doesn't actually adhere correctly. And then again, we have to recognize that the areas above and below that fusion need to move. And so as we increase movement in those areas, then we end up with injury to those areas. So it's very much like the lumbar fusions that we talked about, where the SI joint tends to have a bunch of problems because the SI joint wants to move and there is no movement above it. So it's the same kind of problem. We end up having maybe irritability of the upper thoracic spine, irritability of the upper cervical spine following these kinds of fusions. So if you do get to see these patients before their surgery, which again is pretty rare, we're basically helping them understand like how to position themselves so they don't end up with a lot of nerve root irritability. And then we're giving them very basic exercises to turn on their scapula, to allow for the thoracic spine to move, and then stretching soft tissue around the area. So after surgery, we're calling the first phase weeks 0 to 4. You might not see them immediately after surgery. In China, you never see them immediately after surgery, but maybe you will. And so if you do, you're basically going to make sure that they understand how to use their cervical collar, because every surgeon in China gives them a collar after surgery. If you listen to the video, they say sometimes you wear a collar, but I know in China, everybody wears a collar. So they need to be comfortable with using that, taking it on and off. And then our goal over the first 4 weeks is that they become independent in their ADLs. So they really should be able to perform most of their normal life stuff, even though they're wearing a cervical collar. We also want to make sure that they are not getting deconditioned. There's no reason why they can't walk, why they can't bike, why they can't do activities during this time period. So we want to make sure that they are staying as active as they can. So again, we're trying to teach them appropriate posture and control of muscles. If they're in a cervical collar, obviously we're not going to be able to do a lot related to muscle groups, and we don't really want to start doing deep neck flexor exercises at this point. But we want to make sure they understand that they should avoid any extension movements, especially if they've had an anterior approach, so that they don't pull on that anterior tissue. And then their upper extremity movement does need to stay limited during the first 4 weeks. So what we say is you're never lifting more than 5 pounds, which is about 2 kilograms. And you're never doing anything with your arms above shoulder height during these first 4 weeks. And again, we know that there's going to be a collar that gets used, and we need to be sort of careful with how we do showering. but they can shower after just a couple of days if they need to do so, which of course everybody wants to do that, so that's fine. So again, there isn't a lot of restrictions. They can shower obviously without the brace after a couple of days. This is the very aggressive approach that we take in the US, and I recognize that that's not always how you see it in China, but I'm just letting you know what it looks like and where the research is from the United States, from the West. So during this first 4 weeks, you're going to be helping them with understanding how to breathe from their diaphragm. That's a big part of this because we don't want them overusing their scalenes for breathing. And unfortunately, a lot of these people were likely using their scalenes a lot with activities, and that's part of why they had their symptoms. And so we want to make sure we're teaching them how to breathe from their diaphragm, as well as helping them just do basic transfers and movement patterns. Exercises are going to be pretty basic as well. We're doing a lot of lower extremity things, a little bit of scapular exercises, things like the bike if they have access to a bike. And so our goals and our milestones to progress to phase 2 are very, very basic. We really just want them to be able to perform normal ADLs and lower extremity exercises regularly. Our second phase starts from week 4 to 8. And again, this is really related to fusion. So if they had something less than that, if they had a discectomy or a laminectomy, then we probably can move a little bit faster. But when we think about fusion, it's during the second phase, so basically the second month, that we start to increase more of our range of motion of the neck. So we should be able to do a little bit of passive range of motion as well as active range of motion of the cervical spine. We're hoping that the surgeon allows them to get out of that cervical collar during the second month. And I will usually just recommend that they use it if their neck feels tired. So if they're feeling like they can't hold their head up anymore, they can put the collar back on. They can put the brace back on. But otherwise, we really want to try to get them out of the brace during the second month. So our treatment is going to be to start moving the arms a little bit more. We're going to start doing things like the upper body arm bike with no resistance. Again, we don't want to be pushing the arms too hard, but we do want to start using them. We also want to have good range of motion of the upper extremities. We can start then doing some weight bearing through the arms, things like wall push-ups. We can also start doing cervical isometrics. So very, very basic. Let's turn on the muscles around the neck without doing resistive activities with the neck muscles. We also really want to make sure the thoracic spine is mobile. So we talked about the fact that the thoracic spine and the upper cervical spine need to move if there was a fusion of the lower cervical spine. And so at this point, we can start really doing a lot of thoracic mobility exercises as well as scapular exercises, and then keep up those cardiovascular things like walking and the bike. So by the end of the second phase, so the end of the second month, we really should have good and full upper extremity range of motion. We also should be able to turn on the muscles around the head. We don't need to have full cervical range of motion, but we need to be able to turn on those muscles without pain. So our third phase is from week 8 to 12. So again, this is about the third month or so. And this is when we can really start doing active range of motion of the cervical spine. So in phase 2, we were doing active range of motion of the shoulders and just starting some basic active range of motion and passive range of motion of the neck. But during this third month is when we really start doing active range of motion of the neck. We also can start strengthening those neck muscles. So the isometrics, we're just turning those muscles on, and now we're going to start strengthening. We also can start lifting. And so the goal is to be able to lift less than 20 pounds, which is about 8 kilograms without any problems. So we want to be able to lift shoulder level or below up to about 8 kilos. So our treatment during this period is adding resistance to that arm bike, and hopefully you have access to an arm bike, which would be good. And then we're also starting to add resistance to other upper extremity exercises. So we can start doing more stabilization stuff, more TheraBand stuff, a little bit with weights, again, as long as it's under 8 kilos. We can start adding resistance or endurance to our neck exercises. So things like chin tucks, holding the head in a neutral position and side lying, those kinds of things. And then we can also start doing deep neck flexor exercises in the 3rd month. So again, we're waiting a while before we really start doing a lot of that kind of stuff. But our goals is that by the end of that 3rd month, we have full pain-free range of motion of the neck. And again, this is, when I say full, if they have multiple levels that were fused in the lower cervical spine, we're not expecting rotation to be more than about 45 degrees. We're not expecting flexion and extension to be significant. So when we say full, recognize that those fusions are going to obviously affect what their full range of motion looks like. So return to sport or sport-specific training starts at about the 3rd month and later. And as long as they're pain-free and they're demonstrating that they can do walking and biking and things without any symptoms, they can actually start running again. So they can start jogging and running after 3 months. They also can return to everything that they need to do at work. But of course, if they have a very physically demanding job at work, then we're going to probably need to do some work conditioning type things. And obviously anybody who's at a desk, we need to talk about ergonomics. We need to talk about things like keeping their head in the right position, their shoulders in the right position with their desk work. So those are very important things that need to happen over so again, after about 2 or 3 months. It really isn't until after 6 months that they can go back to high intensity or contact sports. So we're saying that jogging and running is okay after 3 months, but if they're doing contact sports, then we really want to wait until about 6 months before we start those things. So here's a couple of references for this one. The rehab itself is not terribly difficult. I tend to do a lot of soft tissue work and mobilization in the thoracic spine and the upper cervical spine. But also we want to make sure that the muscles around the cervical spine are working well. You'll notice that we didn't put anything about nerves into this treatment pattern or protocol. And that's really because most of the time the nerve symptoms have decreased and they're not very significant. But if this is a patient who's had a lot of nerve problems, upper extremity nerve problems, or even lower extremity nerve problems, then your treatment is going to focus a little bit more on nerve glides, so that radiating pain pattern that we talked about with the cervical guidelines. So you're going to think about doing nerve glides. You're going to think about strengthening specific muscles related to myotomes that might be weak. So those are all things that you need to consider following surgery. But a lot of these patients, by the 1 week or 2 weeks later, are going to tell you, wow, the numbness is gone. I don't feel as weak anymore. But you definitely want to test those things so that you can treat them if it's necessary.